Welcome to Allard USA and this webinar on upper extremity orthotics. The focus is on the wrist and hand. That complex is amazing in its complexity and in its abilities to perform a multitude of tasks. It is worth our time and effort to understand it a little more and to appreciate well-designed interventions that can help keep it or return it to function. The program will start out with a review of the anatomy of the wrist-hand complex. We'll review orthopedic-related wrist-hand issues and determine the correct orthotic interventions. Then, our focus will shift to the post-stroke hand, the challenges it presents, and the goals of keeping or making it functional again. Finally, we'll look at a resting hand splint and a thumb splint that have the potential to optimize compliance and functional outcomes. The hand is one of the most complex and beautiful pieces of natural engineering in the human body. It gives us a powerful grip, but also allows us to manipulate small objects with great precision. The versatility sets us apart from every other creature on the planet. Keeping it functional or restoring its function is a very worthwhile cause and a high priority. In what may seem to be a too elementary review for our audience of medical professionals, the distal and middle phalanges are noted here. The joint between those two bone segments is the distal interphalangeal joint, or the DIP. Amputation of just one distal phalange or loss of motion in just one DIP can create significant functional deficits in the hand. The proximal phalanges are shown here. The joint between the proximal and middle phalanges is the proximal interphalangeal joint, or the PIP. Because there are only two bony segments in the thumb, there it's called the interphalangeal joint, or the IP joint. A fixed contracture in just one of these joints in a finger can also create significant functional deficits to that hand. MCP joints, sometimes referred to as MP joints, are where the fingers move with respect to the hand and are important for both power grip and pinch activities. The MCP joints allows for bending and flexing fingers, spreading fingers, and bringing the fingers together. Fingers can be spread more easily when they are straightened rather than bent because the collateral ligaments are loose when the finger is extended. The carpometacarpal joints are the bony articulation between the hand and the wrist. The small finger, CMC joint, has the most motion of any finger joint, with the exception of the thumb. This makes the hand more flexible and permits the hand to change its shape and adapt to grasping objects of different sizes and shapes. Because this joint is more mobile, it is more common to have a fracture or dislocation, particularly when it is hit by a hard object. The wrist serves as a bridge between the forearm and the hand. Its movements, including flexion, extension, abduction, and adduction, are facilitated by forearm muscles. Wrist range of motion, though, depends largely on the osseosus articulations of the carpal bones. In the sagittal plane, there's a nominal 60 degrees of active range of motion towards both flexion and extension. There is a pretty wide variance in literature regarding the range of motion at the wrist in the frontal plane. In general terms, the wrist has an active range of motion of about 20 degrees of radial deviation or wrist abduction. The wrist has an approximate active range of motion of 30 to 40 degrees of ulnar deviation or wrist adduction. When the hand-wrist complex is in anatomical neutral with palms facing forward, the wrist is fully supinated. In supination, the radius is parallel to the ulna. To transition from supination to pronation, the radius crosses over the ulna, which doesn't move at all in the transverse plane. Therefore, the ideal posture in which to fit a wrist-hand orthosis is in supination. This optimizes the purchase of the device on the bones of the forearm while they are parallel instead of crossed. By definition, opposition is the rotational movement of the first metacarpal around the long axis of its shaft. The range of motion for opposition allows the thumb to touch the base of the fifth finger. This is an incredibly important fine motor skill, as it allows the hand to grasp and use tools and objects efficiently by rotating the thumb so it can touch the fingertips. Opposition is used when grasping eating utensils, a hammer, or a paintbrush. Opposition of the thumb and fingers is also used to grasp and manipulate small objects. It's estimated that the human hand would lose over 90% of its function if it didn't have opposition. This section of the program deals with conditions commonly seen involving the wrist-hand complex. A retinaculum refers to any region on the body in which tendon groups from different muscles pass under one connective tissue band. In the wrist, these bands can also be referred to as transverse carpal ligaments. The extensor retinaculum is a strong fibrous band extending obliquely across the dorsal aspect of the wrist. It holds the extensor tendons at the dorsum of the wrist to prevent bowstringing of those tendons, which would lead to loss of power of the extensor muscles. The hand flexor retinaculum is a strong fibrous band which bridges the palmar or anterior cavity of the carpal bones. It attaches to the bones near the radius and ulna, thereby creating the roof of a tunnel through which pass the tendons of the finger flexors. There are 8 tendons that pass through the carpal tunnel. These tendons are the flexor digitorum profundus, that flex the DIP joints, and flexor digitorum superficialis, that flex the PIP joints. Those tendons are all surrounded by a single synovial sheath. The tendon of flexor pollicus longus, that flexes the thumb, is surrounded by its own synovial sheath. These sheaths allow free movement of the tendons within the tunnel. Because of the limited space within the tunnel, when tendons become swollen, they can put pressure on the median nerve. This nerve innervates the thumb, second, third, and medial aspect of the fourth fingers. The lateral aspect of the fourth and the fifth fingers are innervated by the ulnar nerve, which crosses the wrist superficial to the flexor retinaculum. Anything that squeezes or irritates the median nerve in the carpal tunnel space may lead to carpal tunnel syndrome. A wrist fracture can narrow the carpal tunnel and irritate the nerve, as can the swelling and inflammation caused by rheumatoid arthritis. Sleeping with the wrist positioned in terminal flexion can cause flexor tendons to swell. Overuse syndromes, especially those associated with vibration, can also cause flexor tendons to become swollen, which would then put pressure on the median nerve. When the median nerve is compressed, the symptoms can include numbness, tingling, and weakness in the hand and arm. Some patients feel something like an electric shock in these fingers. Some patients can experience weakness in the hand or in the thumb's pinching muscles. Symptoms generally start slowly and then progress to more debilitating conditions. A severely immobilizing wrist or hand orthosis is generally not indicated for carpal tunnel syndrome. A single pole and double pole 6-inch or 8-inch lace supports are usually enough to keep the hand-wrist complex in a more neutral posture and out of the terminal ranges of motion. These lace-style supports are relatively friendly for the senior and geriatric populations. These types of devices may be worn at bed rest if so ordered by the prescriber. 6-inch or 8-inch wrist supports with strap closure can be effective but are generally more suited to younger or more active patients. The geriatric patient who may have some hand tremor issues could be challenged by applying these devices if a strap comes out of its D-ring. De Quervain's tenosynovitis is an overuse condition that affects the tendons in the wrist in the area of the first CMC. It occurs when the two tendons just proximal to the CMC joint under the lateral extensor retinaculum become swollen. The swelling causes the sheaths or casings covering the tendons to become inflamed. This puts pressure on nearby nerves, causing pain or numbness. Wrist-thumb orthoses are generally indicated to help manage de Quervain's tenosynovitis. These devices should hold the thumb in its neutral posture while blocking motion towards ulnar deviation or wrist adduction that would stretch the involved tendons. Gamekeeper's thumb, also known as skier's thumb or a UCL tear, is an injury to the ulnar collateral ligament of the thumb. The UCL may be merely stretched or it may be torn from its insertion site into the proximal phalanx of the thumb. In approximately 90% of cases, part of the bone is actually avulsed from the joint. Most gamekeeper's thumb injuries are treated by simply immobilizing the joint with the thumb spica. This protects the disrupted structures while allowing the rest of the hand to function. Stabilizing the IP joint may offer additional protection for this disrupted ligament. If the ligament is torn from its insertion point, it generally remains relatively undisplaced and responds well to thumb spica intervention. There are a vast number of orthopedic-related injuries that can happen to the hand-wrist complex, from subluxations to dislocations to fractures. Each has its own impact on the function of the hand, and all may benefit from orthotic intervention. There is an equally vast number of hand-wrist orthotic devices that can be appropriate to help manage all those injuries. Determinations must be made as to the length of the lever arm that is required to support the level of disability involved with the injury. The desired functional goals of the patient should also be considered when selecting the optimal level of support. The bullet points in this slide are a few of the considerations in choosing just enough support for the dysfunction without overbracing the hand-wrist complex. Most of the conditions discussed so far have been more orthopedic-oriented. We'd also like to spend time on the neuro-involved wrist-hand complex. Neglect or improper management of the post-stroke hand can leave a lifetime of significant disability or inability to perform the most basic activities of daily living. According to the Center for Disease Control and Prevention, nearly 800,000 individuals have a stroke every year in the U.S. That's about 1 every 40 seconds. Resulting in a death from stroke about every 4 minutes. In 2018, strokes were the 5th leading cause of death in the U.S., following heart disease, cancer, accidents, and chronic lower respiratory disease. The highest incidents of stroke occur in the southwest part of the U.S. The risk here is 30 to 40% higher than the rest of the U.S. Diet, obesity, and high blood pressure, along with some genetic influences, combine to make this area the so-called stroke belt of the U.S. Ischemic strokes make up 87% of all strokes. They are caused by a fatty buildup that occurs when plaque breaks off from an artery and travels to the brain. Plaque can also build up in the arteries that supply blood to the brain and narrow those arteries enough to cause ischemic stroke. 13% of strokes are hemorrhagic strokes, or so-called brain bleeds. This type of stroke is often associated with high blood pressure, but could be caused by a congenitally weak blood vessel in the brain. If a burst cerebral aneurysm causes a hemorrhage, a surgeon may remove part of the skull and clip the artery. That procedure is called a craniotomy. People who have a brain hemorrhage leading to a stroke have a 25% chance of having another one in the future. A transient ischemic attack, TIA, is a temporary period of symptoms similar to those of a stroke. A TIA usually lasts only a few minutes and doesn't cause permanent damage, often called a mini-stroke. A transient ischemic attack may be a warning. About 1 in 3 people who has a transient ischemic attack will eventually have a stroke, with about half of those occurring within a year after the TIA. Anyone can have a stroke at any age. They can even happen during gestation before birth. But the chance of having a stroke increases with certain risk factors. Some risk factors for stroke can be changed or managed, while others can't. Everything in this list can be medically managed or changed except for the last item. Whatever the type of stroke or the risk factor, it is a medical emergency if one occurs. Seek medical attention immediately. Individuals suspected of having a stroke should not be allowed to walk on their own because balance and coordination are often impacted by having a stroke. Attempts should be made to keep the person calm because patient agitation could exacerbate the injury to the brain. Individuals suspected of having a stroke should not be allowed to walk on their own because balance and coordination are often impacted by having a stroke. Attempts should be made to keep the person calm because patient agitation could exacerbate the injury to the brain. Stroke and cardiovascular disease is number 4 in the list of leading causes of long-term disability. It follows cancer, back disorders, and accidental injury, which are 1, 2, and 3 in the list of causes leading to long-term disability. There's no cure for stroke once it has occurred, but advanced medical and surgical treatments are available. These can help minimize the consequences of a stroke or reduce the risk for another stroke. Besides the more visible symptoms of a stroke, there are many invisible consequences to having a stroke. Mental acuity, logic, and situational awareness may be dampened by stroke. The ability to learn, make logical judgments, or remember are often in the list of sequelae that are not visible but very real. Changes in the emotional status often occur as a result of having a stroke. A person who is generally upbeat and positive may become depressed and despondent. The person who is stoic may become very fragile emotionally and cry in response to minor emotional triggers. Associated with the loss of muscular function of half the body is the associated loss of feeling in those affected areas. A stroke patient may not be able to use a hand, but they also lack the usual sensation of where that hand is in space, or when the hand is subjected to pressure or pain. It's not unusual for the stroke patient to be challenged by chewing and swallowing, leading to the need for therapy to regain those functions. Bowel and bladder control may need to be more actively managed if the automatic responses of these systems are negatively impacted by a stroke. The active management of those symptoms are similar to those used by spinal cord injury patients. CPRS, or what used to be called reflex sympathetic dystrophy, is not uncommon in this patient population. Moving closer to the orthotic implications of stroke, the loss of sensation and proprioception can lead to spasticity that can lead to deformity. Muscles pulse between relaxed and contracted because of the lack of proprioceptive input, leading to a lack of neural control from the cortex. The sooner this situation is addressed with appropriate orthotic control, the better the outcomes can be in minimizing the extent and severity of the spasticity and resultant deformity. The lack of ability to use the upper extremity for activities of daily living are significant and can lead to loss of independence and a significantly diminished quality of life. The challenges cover the gauntlet of personal hygiene to nutrition and feeding oneself to security and closing and locking doors. Orthotic intervention for helping to manage the stroke-involved upper extremity is as complex as the symptoms themselves. One of the primary goals is to maintain neutral posture or to return the hand-wrist complex back to a more neutral posture. This will help optimize the return to function as the patient works through occupational or physical therapy. The device should help avoid or alleviate pain by maintaining neutral posture and positioning the hand-wrist complex for potential return to function. Controlled compression over the entire area can minimize windowing edema associated with straps, while facilitation enhanced venous returns to minimize potential for pain. Anatomical positioning associated with compression can help control and reduce exaggerated, uncontrolled muscle activity while helping maintain a more neutral posture. Doing so can help with alleviating or minimizing pain and help avoid formation of deformities associated with spasticity. This positioning can help address global hand-wrist deformity issues, but also help with various deformities in the fingers. Managing these issues can help assure maximum future functional potential. Mallet finger, boutonniere deformity, and swan neck deformities can all be addressed with a broad resting platform in an anatomical position. There are 4 arches within the palm of the hand that enable the hand to grasp objects of different sizes and shapes. These arches direct the skilled movement of fingers and control the power of a person's grasp. The arches include a proximal transverse and a distal transverse arch, 1 longitudinal arch and 1 oblique arch. Maintaining these arches during orthotic intervention is critical to the future function of the hand. The arches will be further defined later in this program. A well-designed orthosis would help prevent injury to soft tissue while serving to resolve the usual hygiene issues associated with wrist-hand contractures. The goal is always to improve the chances of the post-stroke patient being able to manage their activities of daily living to the greatest extent possible. Broad compressive coverage over the hand-wrist complex can serve to avoid or help resolve edema that can result from the loss of the muscle pump. Uncontrolled edema can lead to chronic pain and more permanent functional deficits in the fingers and hand. Restoring the biomechanical alignment of the hand can help relax contracted or spastic muscles, thereby improving or maintaining a more neutral posture. The low-load prolonged stretch protocol is recognized as the best way to lengthen muscles and to keep them there. Once muscles are lengthened, they may have the potential to reacquire functional capacity. In using commonly available prefabricated products, some shortcomings appear to be all but universal. There's significant potential for the straps to cause or exacerbate the edema that is common in this patient population. Designing a device that avoided the edema issue by facilitating venous return was a high priority. Virtually all of the devices were also relatively bulky. This bulk contributes to making dressing the patient more difficult, and the appearance of a bulky brace makes the brace impractical in the lives of recovering stroke patients. Developing a device much less bulky was another high priority for the design team. Most devices were only marginally cleanable or are difficult or impossible to launder. Having a device that is easy to launder was a pretty high priority in developing a new device, especially since this is for a patient population that has functional deficits that make eating and hygiene more problematic. Some devices that are available put the wrist-hand complex into positions or postures that in no way resemble neutral or functional postures. The design team determined that the device had to position the wrist-hand complex in a way that optimized anatomical and biomechanical alignment and posture. Meeting this goal would optimize the potential for return to function with the help of a rehab team. This illustrates a very typical presentation of the unmanaged or neglected post-stroke hand. It will usually be positioned in flexion with an ulnar deviated wrist, flexion and adduction of the thumb and all of the fingers. This hand is unable to perform many of the functions required to maintain normal activities of daily living. Orthotic intervention should include a double 3-point device to control the deformity in both the sagittal and the frontal planes. In the sagittal plane, the 3 points of pressure to be used are at the proximal forearm, over the axis of the wrist joint, and of the palmar section of the hand to control flexion contracture of the wrist and fingers. Orthotic control in the frontal plane includes 3-point pressure that should be applied at the proximal lateral side of the arm, the lateral side of the hand and at the base of the fifth finger, and the medial side of the wrist to control ulnar deviation of the wrist and fingers. The product should be delivered in the posi position, also known as the intrinsic plus position, that is described in numerous studies. The angle of the wrist should be approximately the same as when the hand is tight in a fist laying on a flat surface. The forearm should be halfway between supination and pronation, and the thumb slightly extended and abducted. The MCP joint should be almost extended and the IP joints a little more flexed. It's important to find the optimal resting position for each particular patient. The proximal transverse arch is formed by the distal row of carpal bones. This static rigid arch forms the carpal tunnel, permitting passage of the median nerve and many flexor tendons coursing towards the digits. As with most arches in buildings and bridges, the arches of the hand are supported by a central keystone structure. The distal transverse arch of the hand passes through the metacarphalangeal joints. In contrast to the more rigid proximal arch, the ulnar and radial sides of the distal arch are relatively mobile. To appreciate this mobility, imagine transforming a completely flat hand into a cup shape that surrounds a baseball. The longitudinal arch of the hand follows the general shape of the second and third rays. These relatively rigid articulations provide an important element of longitudinal stability to the hand. Transverse flexibility within the hand occurs as the peripheral metacarpals, first, fourth, and fifth, fold around the more stable central, second, and third metacarpals. The oblique arch is the last of these features in the hand, and an important one in that it facilitates opposition. Without the ability of the thumb to touch the rest of the fingers, the hand loses most of its function that separates humans from the rest of mammals living on planet Earth. As is the case with most orthotic interventions, managing the patient early before spasticity and contractures are formed is far superior to trying to manage those issues after they're fully established. Early management can help minimize contractures and deformities, help facilitate venous drainage to avoid edema, and help the hand relax. The use of an apparently simple but well-designed solution to help manage the post-stroke hand-wrist complex can lead to better patient compliance and better functional outcomes. A new state-of-the-art device now exists to help manage these types of patient presentations. The name might sound strange, but the design and technology that went into developing the Smart Orthotic Treatment, or SOT, resting hand splint were world-class. Engineering, design, material sciences, and medical professionals with expertise in wrist-hand management collaborated to develop the SOT resting hand splint. The brace is delivered in a resting hand position that can offer pain relief and relaxation to the hand. It also provides an ideal biomechanical position that may reduce the risk of flexor shortening of the wrist and fingers. The splint is laminated with different layers of material. In the core is a pre-shaped aluminum stay that is covered with polyethylene foam to ensure patient safety and comfort. This is particularly important if the splint is used at night so the patient doesn't hurt themselves or his or her partner in bed. The material used for the cover tabs is comfortable for the patient and will slide easily beneath clothes. The resting splint is created by pressing the layers of materials to the reshapeable aluminum stay. This creates a sealed and washable product that optimizes patient safety, comfort, and compliance. The stay is pre-shaped in the posi or intrinsic plus position to maximize the benefit of the splint and to minimize the customization that may be required at the time of fitting. To remold or customize the orthosis to the posi position or intrinsic plus position to meet the needs of an individual patient, adjust the distal section of the splint. Flex the area at the MCP joints to about 60 to 80 degrees of flexion. This will define the distal palmar crease of the hand. Put the hand in the splint and mark the product where the crease is. Bend the splint at the joint. After that, the area for the IP and DIP joints should be straightened to full extension. Many other products made for the post-stroke hand have straps that can lead to formation of edema. This device places the wrist and hand in a more neutral position. Then the application tabs broadly distribute pressure on the volar and dorsal aspects of the hand and arm to minimize edema by facilitating venous return. It is easy to fit since it is one wrap. It is intuitive because there are no longer straps to figure out. The broad compression support also enhances proprioceptive feedback at the distal extremity to reduce the potential for spasticity. After the orthosis has been shaped to the individual needs of the patient, insert the thumb into the pocket sewn into the cover. With that in place, secure the center tab just proximal to the wrist. This should fit comfortably snug. Too loose and it will fail to provide the support the patient needs. Too tight and it could restrict venous return out of the distal extremity. Close the proximal tab and then the distal tab on the ulnar side, again making sure they provide firm but comfortable support. Finally, fit the distal tab over the thumb to hold it in the splint in a relatively thumb-neutral position. When the orthosis is to be used during a rehab session, the cover can be folded back so that the MCP joints are free. An extra strap is placed over the fingers as shown. This allows the rehab team to work with the patient with the fingers more accessible. There are 3 accessories to the SOT resting hand splint. The finger separator is attached by Velcro hooks. These dividers help prevent skin irritation between the fingers and can contribute to better positioning of the fingers at the ulnar radial deviation. The second accessory is a separate strap for better control of ulnar or radial deviation when that's required. It is applied at wrist joint center to help correct or stabilize frontal and sagittal plane alignment at the wrist. This strap is applied to the lining on the ulnar side and wraps around the dorsal wrist and passes over the radial side to hold the wrist in position on the orthosis. Position the extra strap onto the middle tab on the cover so that a piece of hard Velcro protrudes from that tab. If there is severe ulnar deviation that needs to be controlled, the aluminum stay can be shaped to create a wall to help control that motion. This should always be done in conjunction with a separate strap that is designed for extra support in this area. The third accessory is wedges that are available in 3 sizes to quickly and easily change the position of the MCP and IP joints. The degree of stretching is changed during treatment using SOT wedges to achieve gradual change. With the high part of the wedge distally, the stretch of the long finger flexors, flexor digitorum profundus and superficialis, increases. To increase the extension of the wrist without reshaping the orthosis, put the wedge in the back of the orthosis with the high part at the back. The SOT resting hand splint is an OTS product that is pre-shaped to maintain the 4 arches in the hand in a validated neutral posture. The pediatric sizes are available to help manage those patients at an early age to help get their development off on the right foot. This splint can be machine laundered using a garment bag. Close all the Velcro first. It is easy to fit since it's one intuitive wrap as opposed to having to deal with separate long straps. The adult sizes complete the size range offering. The aluminum frame inside holds the fingers and wrist in a resting position. From this shape, it can be further molded or modified according to specific patient anatomy or needs. It also supports the MCP of the thumb. Indications for the SOT resting hand splint include most, if not all, of the neurological diagnoses that lead to upper extremity spasticity and contracture. For individuals with a diagnosis of anything from stroke to cerebral palsy, appropriate management of the wrist-hand complex is critical in their potential for future function and relief of pain. There's a whole laundry list of indications for the SOT resting hand splint in the other than neurological category. Wrist and digit fractures are high on that list. Also included are the many and varied tendon and ligament disruptions that can affect the function of the hand that need to heal in a neutral posture. To summarize a smart orthotic treatment resting hand splint, the core of the product is an aluminum splint that is pre-shaped to the intrinsic plus resting hand position. It is covered in foam and sealed in a washable fabric. The shape supports all four arches of the hand and puts the hand in the best possible posture to help relax muscles and resolve or avoid deformities. The cover for the support is lightweight and breathable to optimize patient comfort. Because it is just one piece, it's intuitive and avoids the confusion associated with several long straps. The compression offered by the cover enhances proprioception to minimize spastic muscle activity. Finally, because the frame is padded, there are no sharp edges on which a patient could hurt themselves or his or her caregivers. The cover helps reduce the risk of edema by supporting venous return out of the distal extremity. The SOT resting hand splint comes with a 30-day warranty to be free of manufacturing defects. There is also a 10-day patient satisfaction warranty, so it can be tried on a patient and returned within 10 days of initial fitting if it does not produce satisfactory results. Allard does not recommend any reimbursement code. Having said that, codes have been mentioned to us that offer coverage for this orthosis. It is an off-the-shelf product that is pre-shaped but may need additional bending or molding to fit a specific patient to help manage their specific presentation. The symptoms associated with carpometacarpal or CMC joint injuries are similar to those of arthritis, including pain, stiffness, and swelling at the base of the thumb. Those same symptoms can occur after gripping or pinching activities, such as turning a doorknob, buttoning buttons, or cutting vegetables. Aside from wear and tear, one of the most common causes of carpometacarpal joint injury is subluxation of the first carpometacarpal joint. The SOT thumb orthosis is designed to restrict movement in the CMC and MCP joints and to support the hand's arch. This is done by positioning the thumb's joints and muscles in a comfortable resting position. The SOT thumb will help stabilize overstretched ligaments that can lead to joint subluxation. The SOT thumb orthosis has an adjustable aluminum core that can be easily formed to fit individual anatomy and can be adjusted as needed to meet the changing needs of each patient. This unique SOT thumb orthosis makes an excellent alternative to a custom-made thumb orthosis. The indications for the SOT thumb include both osteoarthritis and rheumatoid arthritis, contracture of the thumb adductors, and carpometacarpal joint subluxation, and overload injuries. It supports the CMC joint while still allowing opposition to maximize the functionality of the hand. The SOT thumb comes in 3 sizes and left and right. The measurements are the width at the MCP and the length from wrist to the end of the finger. This size range should fit most of the adult population. Allard does not recommend any reimbursement code. Having said that, codes have been mentioned to us that offer coverage for this orthosis. It is an off-the-shelf product that's pre-shaped, but may need additional bending or molding to fit specific patient to help manage their specific presentation. The list of references is available upon request. This program covered a lot of ground on content that isn't always addressed in the O&P community. The 4 arches are indeed important considerations in the orthotic management of the hand. Using compression to help mitigate spasticity is a relatively new and exciting consideration. Patient comfort, compliance, and outcomes? These subjects will never get old. Thank you for choosing to spend this time in this program. We appreciate that you could have been doing a whole host of other things, but you chose to be here instead. For that, we thank you.